I'll start with a couple of disclosures. I'm going to speak about Woman Lab, which is a knowledge dissemination platform that we're building in our lab now in an effort to make sure that the whole world knows as much as we know, and that every woman knows what she needs to know about preserving and recovering sexual function after cancer. I am the founder and co-owner of an information technology company that has nothing to do with this presentation, so I won't even mention its name, but I feel it's better to be a proactive disclosure than the alternative. The objectives for today are to recognize the scope and mechanisms of impact of cancer on female sexual function, and we've certainly had many insights to that already today. I'll try to just put a finer point on it, or at least my point of view, from a practicing gynecologist who takes care of women every week for now more than 10 years, specifically women with cancer and sexual function difficulties. I'll hope that you will be able to apply knowledge about female sexual function to improve cancer outcomes, and that you'll systematically incorporate sexual function into cancer counseling and care. And I agree with the comments earlier. Dr. Stryker, who was one of my mentors and teachers when I trained here, I don't expect that every person providing cancer care would be an expert in counseling or treating sexual dysfunction. That would be a distraction from the critical job the cancer care team needs to do. But briefly, it's amazing how much of a difference there is in terms of experience of the patient and outcomes if we just mention the words in the course somewhere of counseling about treatment planning and treatment recovery. Really not much more is needed than to mention the words and to make sure there's a connection to resources and care if needed. So I love the idea of the bringing the full team, the interdisciplinary team, and so you see some of the players on the team in our lab at the University of Chicago. And I wanted to share my point of view. When I think about how do we preserve and recover sexual function for women affected by cancer, self-care has a huge role to play. Most of us take care of our health most of the time outside of the healthcare setting, including our sexual lives and our sexual function. And most people on the planet Earth, although they equally share a concern for, all human beings share an equal concern for preserving the optimal functioning of our bodies, we have disparate access to specialized resources. And so I think there needs to be a huge emphasis on promoting self-care in all instances, but including for sexual function. And this is why we're creating a knowledge dissemination platform, because anyone with an internet connection could gain access to the specialized knowledge we have. And I'll invite you to contribute, if you like, to that platform, and I'll tell you a little more about it as we get there. We focus on knowledge production and sharing. We need to be evidence generating in order to be evidence-based, and I know that in oncofertility world, the same is true. We don't want to experiment on patients with cancer. Many already come to us literally being experimented upon to survive their cancers, and yet we have to do the best we can with the best evidence we have in order to care for people. And then, of course, we deliver direct care. Although lung cancer is obviously still the most prevalent cancer type in the developed world, 2 of every 3 women who survive cancer have a cancer type that directly affects the sexual organs. So when we ask ourselves, like my grandma did, she's 97 and fortunately cognitively intact, what do cancer and sex have to do with each other? I know you spent a lot of time on this. And this is the answer to the question. And she said, I never thought of it, but it makes sense. So when we look at the SEER data, we see, 3 million of 7.9 million female cancer survivors have breast cancer. And we can see the corpus and uterine cancers, colorectal cancer. We have to remember that some people, and the data are not very good, use their anus for sexual activity and intercourse, the cervix. And then there are the other organs like the brain, the head and neck. Really, as the point has been made, virtually the whole body is a sexual organ. And cancer, I will reiterate what's been said, any cancer type can interfere with sexual function. In fact, really, any chronic illness can be a disruptor. These are the characteristics of the women in our program who have registered into a prospective registry so we could track outcomes. Again, inspired by Teresa's idea of asking women to volunteer to register so we could track health and health problems over time. So more than half of the women we see have breast cancer because this reflects the prevalence of this cancer type. But you see, again, the point that really any cancer type can interfere with sexual function. And so we see gynecologic cancers, a growing number of referrals from the hematology cancer groups and others. So I'll share a couple comments from patients, and we've collected a great deal of qualitative evidence over the years. I do want to a trigger warning. For those of you who are not clinicians, the next couple slides do have photographs of surgical procedures involving both male and female anatomy. So if you need to step out or you don't want to look, I just want to give you a chance to do that. So one patient says what reflects, something I hear often. It seems unbelievable to me that a surgeon would remove a woman's sexual organs and never talk to her about sex. But this happens all the time. I'm a culprit. I went through my residency training and consented thousands of women for procedures that directly involved their sexual organs. And never once, and not in our consent form either, did it say anything about what the woman could expect in terms of recovery or change in her sexual function. And another patient said, if somebody were to chop off my husband's penis, they would probably talk to him first about sex. Now, we might say, well, most of the time women being treated for cancer aren't having the anatomical analog of the penis, they're not having their clitoris removed, but women tend to regard those other organs like their breasts, vagina, uterus, ovaries, fallopian tubes also as important sexual organs. So I'm just going to make the point that we've spent millions, hundreds of millions, maybe even more than that, on developing technologies to help men preserve and recover sexual function. And in fact, in the last couple of years, we've seen the first successful penis transplants. Who might need a penis transplant? Perhaps somebody serving in war who steps on a mine. Could be a female too, but we haven't yet attempted clitoral transplant. And we've also perfected surgical procedures to minimize impact on the penis. The penis is susceptible to some of the same diseases that affect the clitoris and other parts of the vulva. And we have a pretty significant literature about how to handle penile cancers in a manner that optimizes sexual function. If we just compare the CPT codes, these are the billing codes, there are multiple specific to penile surgeries, and we have none specific to the clitoral surgeries. We have vulvectomy, radical vulvectomy, simple vulvectomy, but the vulva is a big part of our anatomy with multiple structures. And so these disparities, I think, drive how we even think about preservation and recovery. So the next slide shows some of the images of the procedures we do for women with cancer. So of course, we're familiar with the mastectomy procedure because it's the most common at this point for women with cancer. You see an ostomy here. It might be a little bit harder to recognize. A vulvectomy, which did in this instance include removal of the clitoris, and a hysterectomy, obviously an exceedingly common procedure. And until a couple decades ago, as many as half of women, maybe even a third of women, lived the second half of their life without a uterus. So we've been more conservative in recent years. But how do we do vulvectomies on women? I couldn't even tell you the rate of clitorectomy. This is how I know about the codes, because I tried to query the codes to tell you the rate. Can't tell you. At our center, we probably do 3 or 4 clitorectomies and 30 vulvectomies a year. University of Wisconsin-Madison, I got a similar estimate. But how do we do these procedures without talking to women about the potential effects on sexual function? There are a couple things we should know, because many women who come to care with sexual function concerns, and these are the brave women who figured out a way to ask for help, they come thinking the problem is in their head. Now, sexual function is a mind-body phenomenon. And so yes, of course it involves the mind. And certainly once a person develops a problem, it can cause angst and worry, even depression and grief. So I don't mean to suggest that it's not partially affecting a person's emotions or their psyche. But most of the women I see have at least some physical explanation for their sexual difficulties. So I just want to remind us of what we know about sexual function, and just to demonstrate that there is physiology and endocrinology and anatomy involved. So you've had a second to look for a couple here at what we know about the sexual response cycles in males and females. This comes from the pioneering work of Masters and Johnson going back now several decades, but really this work largely sticks. And I think what's important to know is that some women have a sexual response physiology that looks a lot like the male dominant pattern, but women can express multiple patterns in terms of their sexual physiology. The same woman at different points in her life course, the same woman with the same partner. The woman might express one pattern with one partner and different patterns with different partners. But most women don't know about the sexual response cycle nor the variability in the response cycle. And sometimes I even pull these pictures out to help educate women. One of the most interesting pieces of the picture is, rarely, but sometimes women will complain of, I can't have an orgasm. And so the first question is, well, was that a problem before the cancer treatment, or is that a new problem? Most of the time it's a new problem. It's rare to see primary anorgasmia, but when we do, it oftentimes happens in a scenario, I don't know if the pointer will work, you see that wavy pattern where a woman doesn't recognize that pattern as an orgasm pattern. She's looking for the Hollywood orgasm pattern. And there's one other important misunderstanding that women bring. Women oftentimes come and say, when we ask the question about masturbation, can you have an orgasm with masturbation? Oftentimes the answer is yes, but I can't have an orgasm with vaginal intercourse. And only about a third of women, and again, the studies have their limitations, but only about a third of women will routinely have orgasm with vaginal intercourse alone, without there being some direct contact to the clitoris or the mons pubis. And so when women tend to feel deficient, that they are not having an orgasm if they're not having an orgasm with penis and the vagina, even if they can experience orgasm with masturbation. So I share these things with you because I think they're interesting, and sometimes people probably gain knowledge that helps their own sexual function, so you should get something useful out of the conference. But also just to understand that if we're not specific in how we talk to people, we might really misunderstand the problem. Let's see. With respect to the brain, I was introduced as having an appointment in geriatrics. Are there any geriatricians here? Anyone geriatrics trained? What I love about geriatrics is it's oriented around preserving function, which is exactly what fascinates me with respect to human sexuality in the context of aging and disease. And I teach about changes in sexual function that occur with cognitive decline, with dementia. And so this slide is helpful for the geriatricians to understand how sexual behavior and sexual function relates to the different parts of the brain. But there actually has been quite a bit of science to help us understand the role of the brain in sexual function. And we also know that some of the treatments we use for cancer and the inflammatory aspects of cancer itself, even if it's not directly in the brain, might affect the brain and therefore sexual function. So when women say it's in their head, yes, maybe, and maybe also for some biological or iatrogenic reasons. Iatrogenic meaning things we do to people in the course of medical treatment. And we know a lot about the physiology with respect to the endocrinology and the neurotransmitters involved in sexual function. We learn a lot about the basic science of sexual function by observing unexpected sexual side effects in the process of drug testing. And there's a story about that related to a new drug that's become available to treat sexual dysfunction. But we have to keep updating these slides because every time we test new drugs, we get new insight to the physiology of things. I just want to point out the importance of oxytocin in orgasm. So one way that oxytocin oxytocin release is stimulated is through nipple stimulation during sexual intercourse. So if a woman has her breasts removed, the nipple areolar complex removed, she loses that physiology. It's also important to understand that the nerves from the nipple areolar complex light up the same part of the brain as the pudendal nerves from the clitoris. And so when a woman says, I no longer have my breasts and therefore I'm unable to have an orgasm, we have to understand that her complaint is not hysterical. It's actually a science-based, an evidence-based concern. So we can reconstruct breasts. We've made huge investments in the restoration of the aesthetics, the cosmetics of the breasts. Technology has done, I think, an unimaginably good job in terms of restoration of appearance, of form. But equally so in the negative direction has been our effort to restore function. And if we even look to what is the definition of breast function in our physiology textbooks, it's lactation, period. So the basic science work just to simply understand the sexual function of the breast and therefore how to preserve and restore it needs to be done. And this is one of the areas of work in our lab at this time. There are also peripheral mechanisms, of course, important to sexual function. These are the same hormones I know you think about and we've been talking about today with regard to importance for fertility. And I think I've made my point that there is real physiology behind female sexual function. It's important also to know that treatment for cancer is shown to cause or exacerbate prior loss of sexual function in somewhere between 1/3 and 3/4 of women with cancer. Now, this is a wide range, so it could make us feel skeptical, but let's just assume it's 37%. Let's assume it's the low end. What proportion of women undergoing cancer treatment die as a result of general anesthesia? Fewer than 1%, maybe even 0.1%, thankfully. What percent of women have a bowel or bladder injury or develop a life-threatening infection? Far fewer than 37%. We wouldn't tolerate more than 2 or 3%. But those are the things we routinely counsel women about when we ask for their permission to treat them for cancer, especially when we ask for permission for surgical treatment. So here we have something far out of, orders of magnitude greater risk, even on the low end of the estimate. Now, it's important to share, of course, that there is a baseline prevalence of sexual difficulties in the population. Dr. Stryker cited some numbers earlier from Jan Schifrin's work that sounded high to me, and I'll have to look back at Jan Schifrin's study. I made a note to self to do that. But let me share with you at least some evidence from a couple other studies, because I don't think we should overstate the problem. And in the general population, so this was a national population-based study of sexuality among people 57 and older in the United States population. This was a probability sample of the population. So best you can get of a random sample of the United States population. These are the prevalences we see of sexual problems in the United States. So this work was published in the New England Journal in 2007. I think what's important here is a couple things. First of all, you see the numbers are pretty big. I mean, they're not that small. There's a 1% prevalence of pain with sex among men in the 75 to 85-year-old age range, so that's a low estimate. We see that across age groups, and this was cross-sectional, so we weren't following these people over time, although they have now been followed, and the data are publicly available if you want to look at them. But the prevalence of lack of interest is pretty stable looking at men and women across the age groups, although women far higher prevalence of lack of interest than men. So this was about 40 to 50% in women, and I think Dr. Stryker mentioned a number that was a good 20 or 30% higher than that. Erection difficulties in men are prevalent, and they're higher 65 and older. Lubrication difficulties related to menopause are certainly prevalent. And now these are sexually active people. If we included people who are not sexually active, some numbers might go up because they might have dropped out of sex because of problems, or the numbers might go down because those people don't have those problems. A couple points here I think are really interesting. The prevalence of 44 or 45% prevalence of erectile difficulties in men 65 and older is a really high number and needs to be appreciated. And most women in these age groups don't know that. And so they're starting to wonder whether the reason their partner is having erection difficulties is because of how their body looks different after cancer, or because the partner is no longer attracted to them. So just sharing the population-based normative data can be therapeutic. I think the other number that's very interesting is that about 1/4 of sexually active women, 1/4, 57 and older, stable across age groups, are sexually active even though they report sex is not pleasurable. And so this needs to prompt us to think, why then would they be sexually active? And of course, it's a rhetorical question. You could think of the reasons why, but even women who are not necessarily having pleasurable sex do continue to have sex. And some women with cancer who seek treatment, their goal is not, they are not even aiming for pleasurable sex. They're aiming to be able to have sex that is not terribly painful. They're aiming to be able to have sex to maintain the intimacy. In some cases, and my clinic was never busier than when the economy tanked a few years ago, I was seeing women who were afraid that now they had cancer, and if they couldn't have sex, they would be left, and they would be without a roof over their head. So we also have to understand the importance of sexual function for a woman's economic security and the security of her family. Here's another way, and this is from Jan Schifrin's work, to look at the prevalence of sexual problems. And this is where we add not just reporting the problem, but feeling distressed by the problem. So is it a problem? I think somebody asked a question earlier today about low libido. Is it a problem? Well, if you're not bothered by the problem, it's not a problem I'm going to treat you for. It used to be that we would consider a woman as dysfunctional if her partner was distressed by the problem. Okay, so we're not, fortunately, in those dark ages anymore, but when we add the criterion of distress, we see that the overall prevalences of these conditions in this study are even lower than what I just showed you. Now, what about detection? How do we detect these sexual function difficulties? I recommend, and so do most of the organizations, the cancer-related organizations that have commented on this issue, that there be a way to systematically screen for sexual function. Where in the history should we do this? Well, the review of systems is a reasonable place. Many of us have patients complete checklists before they come in. There's just simply no reason why problems or concerns with sexual function couldn't be listed under the GU part of the review of systems checklist. Profiling is inappropriate and it's ineffective. It's discriminatory and it will be a waste of time. It's literally better to not ask anybody than just to selectively ask the people who you think look sexy, might appear to have a marital partner. I mean, it's just a failed strategy. So it's really, I think, all or none, because you can really do harm by profiling. So a patient said, when we were going through the whole cancer issue, it never crossed my mind. No one even mentioned it. But if someone had mentioned it, I might not have cared at the time, but I would have stored the information away and known I could get help if I had a problem. And I see a real difference even in terms of, and this is anecdotal from my expert opinion, I haven't studied this as an outcome, but a real difference in prognosis to recovery for women who come in and say, somebody mentioned this to me, it's been in the back of my mind, I wasn't ready to get care, but here I am now, versus the woman who comes in with the same exact set of problems and feeling really angry that she's 3 years out and she just heard at a Roe event, Recovery on Water, does anyone know that great breast cancer support organization, that her sexual problems might be a result of the aromatase inhibitor she's been taking for 3 years. So same problem with that layer of anger and how could nobody have ever told me, really puts you in a different prognostic category. Many of those patients have become our advocates, and I know similarly, advocates in the room, some of you have channeled your anger and frustration with the way things are to try to make it better for the people after you. So here's some questions have been asked earlier. How do we ask people? There is a validated screener that can be used. This is validated for primary care or general oncology care. Catherine Flynn is a great social scientist at Medical College of Wisconsin. I was a co-author with her and others on this project. It's very straightforward. You can put it on your review of systems checklist. You could ask the questions, but this is very sensitive for detecting clinically relevant sexual dysfunction. Now, the hopeful message here is, in spite of the high prevalence of the problems and the fact that we're not doing a great job talking about it, is that loss of sexual function after cancer commonly has a correctable physical component. And even people who had sexual difficulties before cancer can still recover their sexual function and maybe even do better after cancer. And any one of us who does this work actually sometimes have patients say to us, my sex life is the best it's ever been. My partner and I never talked about sex. We realize how much we love each other in our time together. We realize the value of life. So some people actually experience a benefit to their sex life that's better than it was before. It's useful to know the DSM-V classification of sexual disorders. And if you go back to thinking about the Masters and Johnson sexual response cycle, the disorders align pretty well with the stages of that response cycle. Genitopelvic pain and penetration disorder is very common, especially in women after cancer treatment. I'll talk to you a little bit about more about why we see that problem, and it's also very correctable. Interest and arousal disorder, common, and it commonly comes after a pain disorder, but certainly can also precede pain disorder, and orgasm disorder. Women who've had their clitoris removed, especially if it's not a deep clitorectomy, the nerve going to the clitoris is still viable. So masturbation of the mons pubis area, even without the glands of the clitoris, can be effective for achieving orgasm. And there actually are decent studies on that. But I mean, we just don't tell women this, so they assume they've been castrated. And some are surprised to find that they do have sensation after surgery. The dysfunction, for a person to be diagnosed with a dysfunction, we expect that the disorder persists for 6 months or more and occurs 75 to 100% of the time. For the for the pain disorders, the criterion is persistent or recurrent. It occurs with clinically significant distress for the woman, not for her part. It may also for her partner, but that's not the criterion that diagnoses a dysfunction. And it occurs independent of other relation distress and other medical condition. So I, as a gynecologist, am not using, don't need to use the DSM-V criteria to make a diagnosis, but I do certainly keep these in mind as I'm making diagnoses, and all my patients have another condition, so they wouldn't technically meet these criteria because of that. Here's just a schematic way of sharing the story, that Dr. Stryker did about one of her patients. So a common presentation in cancer is a woman has recovered. She's been told, wait 6 weeks until after surgery for the wounds to heal. Maybe her only procedure was a surgical procedure, so she hasn't started, had chemotherapy, radiation, adjunctive therapy, but she feels a little fearful. Like, is it going to be different? How's it going to feel? Especially if she's had surgery in the breast area or abdomen, genitals, and that's where most of the surgeries occur. She may feel a sense of desire. She's gotten through the stressful part of the cancer diagnosis and treatment. She wants to reconnect, and she may have arousal, maybe a little bit less than she had before, perhaps tempered by the fear. So she and her partner attempt intercourse, and she experiences some pain. This doesn't happen to everyone. Let's just say that, remember, 37% prevalence, so most people, let's say, don't have this problem, but a third do. And she experiences some pain. It might even be that little bit of discomfort she had experienced before, but now it means something different. It feels different. And so then the fear ramps up. So the next time she tries, she feels more fearful, therefore she has less desire. It's even harder to become aroused, and without arousal, you don't get the normal moisture, the normal blood flow. She attempts again, there's more pain, more fear, and then the cycle continues. And this is just sort of a classic presentation. I see it every time I go to my clinic. I see this presentation. And then ultimately, if women go long enough thinking they're the only one with these problems because nobody ever mentioned they might have it, they show up. I have no desire. I don't care if I ever have sex again, except for the love of my partner. They have no ability to become aroused, and they have real difficulty having an orgasm, even on their own. So here are some of the words I hear people say. And if you're caring for women with cancer, these are thoughts they're having in their head, but most of the time not bringing into the cancer conversation. And the reason they won't is they feel it's almost disrespectful to waste the cancer team's time with these issues. Now, if the cancer team brought it up once, they won't feel that way. But if it's never been brought up, they feel like I've been given the signal, I'm out of my lane if I raise these issues here. People say all the time, it feels like I'm ripping. It feels like I'm a virgin again. It's so dry. Cancer is a sex drive killer. Some people become aversive to sex, like repulsed by it even. They'll do anything to avoid a situation where their partner might think they might want to have sex, so they stop holding hands with their partner. They stop looking into their partner's eyes. I mean, they really just wall themselves off. They feel fearful, they're grieving. And a lot of women, like I said before, and this is the injustice, this is the reason I keep getting up and doing this work, is because when we don't talk about it, women feel it's their fault. They think they're the only one. They think it's in their head. It can't be corrected. And marriages and relationships do dissolve because of these problems for the people, especially for the people who don't get help. Let me explain the thing that every human on the planet Earth needs to know about sexual pain, okay? If I could, I need to, it will be a YouTube video. So I commit that to you today. Or maybe somebody's filming this and I could just put this on YouTube. In medical school, we learn about the anal sphincter. And all of you, regardless of your medical training, can see the anal sphincter, and you're all familiar with the anal sphincter because you all use it regularly. And when you walk around town, the anal sphincter is in a slightly or a little bit more than slightly contracted state. Are there any colorectal surgeons in this room? Okay, all right. Well, you can't help me out, but this is, I think, a pretty good explanation. If you need to move your bowels, you have to bear down a little. You have to use some Valsalva, some pressure to move the bowels. That puts some pressure on the sphincter so it can open up a little bit. It has to relax. There is another muscle in this picture that looks an awful lot like a sphincter muscle. It's called the bulbocavernosus muscle. I did my anatomy dissection in medical school. Maybe someone mentioned this muscle. There was no emphasis on it. And then I did gynecology training at, I think, the best OBGYN residency training program on the whole planet Earth. And again, if somebody mentioned bulbocavernosus muscle, it was really few and far between. But I swear this is the most important muscle that you need to know when it comes to understanding women's sexual function. This muscle is a sphincter. And when a woman is walking around with this muscle, it's in a slightly contracted state. When a woman is sexually aroused and she feels safe and desirous of penetration, this muscle relaxes. But when the woman feels fearful, or she's had pain, or all the other things women do, like we chronically sit because we're a computer culture, we're a commuter culture, we have sports injuries, there are a whole bunch of other things that could cause stress and tension in this muscle. But especially when there's been pain or trauma to this body part, the muscle gets tighter. And I showed you the schematic, and then there's fear, and then there's an attempt at sex, and then there's pain, and then the muscle gets tighter. Now, at the same time as there's this continuous cycle of this bulbocavernosus sphincter muscle getting tighter and tighter and tighter, we're blocking her estrogen because she's using an aromatase inhibitor for her breast cancer. Or now we're starting to use aromatase inhibitors where we find estrogen receptor positivity for other cancers, or we're using them to prevent cancer. A lot of people are on these hormone-blocking drugs. These hormone-blocking drugs cause dryness in the vagina, which adds to the pain. And then the vagina, which ordinarily is like an accordion, it has redundancy in the epithelium, so it can stretch and release and stretch and release. Without estrogen, the accordion becomes a flute. So it's a rigid tube. There's not a lot of buffer against friction. Bleeding can easily occur. So now you have a muscle pulling tighter and tighter on this already tight tube, and penetration feels impossible. And what women will say, even more upsetting, is she'll say, it feels like he's hitting a wall. I'm using he in this instance because just the normative is that 94% of the people who come in have a male partner, but it could be two women with a dildo. It feels like she's hitting a wall. It feels like I'm scarred shut. And the worst thing is, a woman who's having pain and a new problem, who's had cancer of any body part, starts to think she's got a recurrence in her vagina. Doesn't matter if it was a head and neck cancer. She thinks there's a tumor in her vagina. She doesn't even want to say those words. And she does this. He hits a wall this far in. Well, what's that far in? That's the thickness of the bulbocavernosus muscle when it's in a tonic, contracted state. I'm so happy how many people are in this room listening to me tell you this. Okay? Forget cancer, women who have pain, young women who have pain. When they try to insert a tampon, same problem. If you're trying to teach a girl how to insert a tampon, you've got to tell her, bear down. That's the trick. So when I do body education, biofeedback with my patients in clinic, Dr. Stryker showed the dilators before. We don't say to a woman, relax. That's a terrible thing to say, especially in that dorsal lithotomy position. It's impossible. What I can say is, though, you have a muscle here just like in your anus, and you need to bear down a little. For women who've given vaginal birth, this is an understandable concept, but the bowel movement works too. Bear down a little, and when she bears down, the dilator can go in. And we start with the tiny, tiny one, and we go all the way up to the size that is her partner. And the woman who walked in thinking she had a tumor, a wall, a scarred shut, a lost vagina, walks out knowing that she has a vagina the capacity of her partner's penis. Like, if I could get $1 million every time I did that, I'm sure we could erase this whole problem from the planet Earth. So I want you to remember the bulbar cavernosus muscle. I want you to tell everybody about it, okay? And I had to discover this just from over and over and over and talking to physical therapists and like, what's going on there? So this condition is called vaginismus. The spasming of the muscle is called vaginismus. It often coexists with a problem called high-tone pelvic floor dysfunction, which is spasming and contraction of the muscles, the hammock of muscles that hold up our entire posture. Men have pelvic floors too, and can also have pelvic floor dysfunction. We can use dilators. There are a bunch of different kinds out there. I am not endorsing any one kind. These are the common ones we see around here. And there's literally no evidence to recommend one dilator type or another. There's little evidence to recommend the best dilator therapy regimen. But they are, based on expert experience, extremely therapeutic, especially in the manner I just described. So what about dryness and atrophy? So a woman who says she's dry isn't just frigid. Like, it's not that she just can't get aroused, it's that we've deprived her of many layers of her vaginal epithelium by blocking her ovarian function, removing her ovaries, interfering with her ovarian function, depleting her of estrogen. And so I was saying before that when we have atrophy, we get thinning, we don't have an accordion, we have the flute. The nerves and the blood vessels are now very close to the surface. This is why women start to bleed. And when women bleed, when they think they no longer have a uterus to bleed, they're assuming cancer has come back. And their partner does too. So I show this picture to people too to help validate, help them understand that the problems they're experiencing are not unexpected given how we're treating them. I do want to make one side point. And this is, I can tell that it's just a terrible picture for you. That population-based study we did to get estimates of sexual behavior and problems in the United States population, we asked every woman in that study if she would do a swab of her vagina. And I can tell you the social scientists on the team gave me a lot of trouble about this, and they thought I was crazy, but we had never had population estimates of vaginal estrogenization in any population. The benchmark data were clinical data from Canada from the 1960s, pre-estrogen, pre any wide use of estrogen in birth control pills or hormone replacement therapy. So we're walking around, see that line that goes down, I'm just gonna tell you the easy story here. The line that goes down was our 1966 based understanding of what happens to estrogen as women age. And the message was, based on serial cross-sectional data, the estrogen levels go down. A woman who's having a problem is having atrophy. Well, we repeated that exact study with population-based data from the United States in 2003 to 5, and what we get is really no age-related decline in vaginal estrogen in our current population. And that's important because we can't just assume that it's atrophy. If a woman is having dryness and pain, she might have graft versus host disease of the vulva. And I've seen that mistake made. We can't treat women with estrogen for dryness if we haven't looked down there and we haven't assured ourselves there's not another explanation for the problem. Common thing, this can happen in the oncology setting, or you could tell your friends, we're using way too much hygiene in the genitals. And as soon as a woman starts to develop pain, she starts to wonder whether she has an infection down there. Some women after hysterectomy might have a different kind of discharge, like just the discharge changes because there's not a cervix there anymore, and she thinks she has an infection. Too many women, and we don't have good estimates, but too many women are putting soaps in their vagina, between their labia, in the vulva. They're using pads day and night. Pads are meant to suck us dry. And that's what happens to the tissues with pads. Women are using wipes all the time. They have all kinds of irritants that without any estrogen around are really caustic to the mucosal structures. Women are still douching. And fortunately, I don't have any patients who are pouring bleach on their bodies, but especially patients living in places where they can't count on consistent water temperature, say public housing, where the water temperature can go from scalding to cold really, really quickly. They tend to take baths more than showers because you can get a steady water temperature, and everybody in a household is using the same bathtub, so they're bleaching or cometing or whatever between every bath. And it's very hard to rinse that out, so essentially they're sitting in bleach baths, which is really caustic. So I talk to every patient about, like, you don't put soap inside your nose and you don't put it in your eyeballs. And the vaginal mucosa, even the mucosal surface of the labia, is much more like the inside of the nose and the eyeballs than it is the skin. And we have to really retrain how people clean. There is self-care for dryness that does not involve prescription treatment. There are moisturizers and there are lubricants. And I do think this is worth knowing if you're on the front lines. Before I tell you more about how those products are used or what the difference is, they are classified, they had been classified in the past as cosmetics by the FDA, and so you can imagine the level of rigor to which they were subjected. At some point, and I can't figure out when, maybe it was because me walking around talking about it, they're now considered Class 2 medical devices. And what makes them a medical device is that they work in a way that does not involve metabolism in the body or a chemical reaction. That's sort of what makes these devices. Nonetheless, they're subjected to less rigorous testing than, say, estrogen. And at the same time, while there's limited evidence to recommend one kind or another, limited evidence of benefit versus risk, meaning scientific evidence, we don't have much evidence to make us worried that using a vaginal moisturizer over the counter is causing a serious problem. I'm just going to let you know that moisturizers are for maintenance. It's a little bit of a mnemonic. For regular use, they have to be used every 2 to 3 days, really for as long as the woman wants benefit from dryness. There's not like use them for a few weeks and stop and you're good. They can be used internally and externally. They usually come with an applicator. So just saying to a woman use a moisturizer if she might have that vaginismus problem is a problem because she's not going to be able to get the applicator in unless she gets help for that problem. Pelvic floor physical therapists are really brilliant at helping people with the problem of inserting or with penetration. Lubricants are for, this is the best mnemonic I could think of, moisturizers, maintenance, lubricants for lovemaking, okay? Moisturizers don't work great to reduce friction at the time of intercourse or dildo or vaginal dilator. Lubricants are for that. They're meant to reduce friction. Water-based lubricants like KY jelly, which is the one everybody says they use. Why? Because gynecologists use that, so everybody assumes that's the best thing to use. They actually increase friction. They evaporate really quickly because they're water, and they get sticky really quickly. Most of my patients like the au naturel route, and they choose coconut oil, which goes from a solid to a liquid really quickly, and it's usually warm. Again, limited evidence to suggest one over the other. Dr. Stryker did talk about the various vaginal estrogen preparations. There are a broad variety of options, I would say, in my practice, and most of the women and oncologists I work with are either recommending a vaginal cream or a tablet. The nice thing about the cream is it can also be used on the external genital structures. Dr. Stryker mentioned that her patient opted for DHEA. It is converted to estrogen. So in a patient, and it has a black box warning against use in people with estrogen-dependent cancers, as do the estrogens, but it, to me, isn't a great substitute for an estrogen for a person who's manicurist, got her worried about estrogen. For those of you who are here for that part, you know what I mean. It's good that we have an FDA-approved DHEA because people were using over-the-counter preparations. We had no idea really what was in those. Can we safely use vaginal estrogen in women with estrogen-dependent cancers? Now, in women without estrogen-dependent cancers, the oncologists I work with have little concern about using estrogen. So in the lymphoma, leukemia patients or the head and neck patients, we really haven't had a concern. For women with estrogen-dependent cancers, obviously, with a black box warning, there has to be counseling, or else even if you prescribe it, people aren't going to use it. The data are limited. We don't have great prospective data, but in large quasi-experimental studies using in women on tamoxifen, we do not see an increase in systemic estrogen, sustained systemic estrogen when we use local hormone therapy. The ACOG committee opinion, which does have influence, recommended that for women with vaginal dryness on aromatase inhibitors, to switch, one strategy could be to switch to tamoxifen and then use a local estrogen for a short duration, and then presumably switch back to aromatase inhibitor. Perhaps I certainly was not at the table when that conversation was had. This seems to me a really impractical solution. Women have side effects going on and off these drugs, and as soon as she switches back, the problem's coming back. So that's the recommendation. I'm not sure how it plays out in practice, or I'm skeptical on how it plays out in practice. For those of you who are sympathetic to this problem, we can preserve and recover sexual function after cancer, but we cannot if we do not talk about it early in the course of cancer, but ideally between diagnosis and treatment planning or treatment implementation. Together with several co-authors, including Dr. Stryker, who spoke earlier, we published an exceedingly detailed explanation for how a new provider to this field can receive a woman with sexual function problems and thoroughly evaluate her and get close to what to do for treatment. But once the evaluation is done, most people who know how to perform a physical pelvic examination can figure out where to go for treatment. So that's the second paper. If you don't have specialists in your community, in your center, find a sympathetic person and just give them this paper and then have them call one of the 12 authors from all over the United States for help. We also published a manifesto, which is an argument for, based on the best available evidence, why we cannot continue to have a world where women are treated for cancer without attention to this issue. And this manifesto, I think, is also, it's what we needed when we made an argument to start our program. And fortunately, we were taken somewhat on faith. But this also, these two pieces together, I think would make it really easier proposition to get somebody engaged. And then last, I mentioned Woman Lab at the very beginning. This has been funded by the Jewish Women's Foundation of Metropolitan Chicago. This is startup funding to help us create a prototype for what it would look like to have a data information dissemination platform where everybody in the world, practitioner, patient, partner, can have access to the specialized kind of knowledge I'm sharing with you. And we're early days. We're populating this with videos. We have patients are engaged just like they're engaged with the Oncofertility effort. We have people contributing blogs, videos, questions, and we hope that you will see this as a resource. And if you'd like to contribute, we'd love to have you as a contributor. Scientific Network on Female Sexual Health and Cancer. I see Sharon Bober has arrived. It's my great colleague with the network, also a member of the steering committee. This is what grew out of inspiration from the Oncofertility Network. We have our next meeting at Duke in the fall of next year. Maybe Sharon knows the exact date, or maybe we don't have it yet. Say it again. September 25th, and we'd love to see you there. Everybody is welcome. I'll thank you, and if there are time for questions, I'd be happy to answer them.
My question has to do with reimbursement. So insurance and reimbursement is something we'll be talking about tomorrow in the cancer context or otherwise. This is reimbursable for the visits that the patients have with you?
In my experience, including taking care of Medicare and Medicaid patients, I have not yet had an instance, and I've been doing this work for 10 years, where a woman called me and said her insurance would not reimburse the visit. She has a cancer diagnosis, and she has physical findings, and if nothing else, menopause as a result, iatrogenic menopause. Typically, my patients have a problem list 7 or 8 long, because in the course of doing the thorough evaluation, the hour-long evaluation to assess these problems, we uncover sleep dysfunction, we uncover urinary incontinence, a lot of those other systemic problems that contribute to sexual dysfunction but are legitimate problems in their own right, and we just have to be thorough in documenting and addressing those issues.
My name is Morishige from Japan. I'm a gynecologic oncologist, and I'm doing every day malignant surgery cervical cancer or uterine cancer. And my question is, in my case, in Japan, we usually treat patient, after treatment. My long career in Japan's oncological survey, very rare patients complain about sexual problem.
Right.
And I heard your lecture, and it was very impressive for me. And my question is there any difference between races? That means in United States, they complain a lot, but
Yeah.
Japanese women doesn't complain
Yes.
or doesn't feel anything, or that's my question.
Yes, I appreciate your question, and I've heard that question in every country I've had the privilege to visit. I heard the question in China, I've heard it in Greece, I've heard it from visiting physicians from other places in the world. I really believe, and the evidence would support, that women, regardless of race or ethnicity, and even of socioeconomic class, are much more similar than we are different. In the United States, while we appear to perhaps be more sexually progressive and liberal than other parts of the world, we're quite puritanical in our approach. Most women do not raise this question with our physicians in the context of cancer care. These data come from new patients seen for a gynecologic oncologic cancer at the University of Chicago. More than 40% indicated an interest to receive care, and fewer than 10% had sought care. More than 40% indicated on their check-in list that they had a sexual function concern, and only 7% of the time did the doctors, the fabulous doctors, and my career depends on them, taking care of them, even notice that they checked yes and actually talked to them about it and sent them down the hall 100 steps to the clinic where I work. It's just not in our workflow. Women of all ages say they believe this is a health issue, they want doctors to address it, and they want doctors to initiate the discussion. It does not have to be a long discussion. It can just simply be, ma'am, I see you indicated you have a concern, and I'm going to connect you to my colleague to take care of it. Or it can be, ma'am, about 37% of women who have this cancer develop some kind of sexual difficulties. Let me know if that's a concern for you. I guarantee if you say that one line, a lot more people will raise their voices.
Okay.
Yeah.
So the problem is our attitude to the patient,
Yes.
or Japanese culture or something like that.
I think our problem is we're stressed. We're trying to save lives of cancer.
Okay.
And we just need to slip it in there when we go through the list of risks of the chemotherapy or of the surgery. I really think that small change, regardless of culture, will make a big difference.
Okay. I'm going back to Japan. I will change my...
You'll send me an email. Yeah. Woo! Yeah.
Hi, my name is Millie, and I trained in India before I trained here again, and I did a full residency there, took care of a lot of patients with GYN. I was a OB/GYN resident there, and I just want to answer the comment why I think in some cultures, including mine, if you have cancer, that's the end of your life. You know, many patients don't get to the point where they're going to survive.
Right.
And then many patients who survive it with all the things, it's such a life-changing event that they will never, ever talk about sex or their sexual life. For the man and for the women, the whole family is devastated and they are almost dead if the woman in that family at a young age has cancer.
Yeah.
So I think it's the same thing. You have to bring it up. They are the same women. Like, I totally agree with what you said. It's the same issues, it's the same things. All the things are similar. It's just the socioeconomic status or their understanding is different.
Yes.
So it's like we have to bring it up.
We have to bring it up. Yeah, thank you.
I can't keep quiet about it because we both deal with this constantly. Maybe you worry people will be offended, whatever. I've never in my whole practice ever seen that happen, ever. Study after study, this is just one, study after study in the urology office, in the primary care office, in the oncology office, talking to the nurses, talking to the doctors, shows they won't ask. They won't ask. They're afraid to ask, and there's a million reasons. You know, they think, well, you've gotten rid of my cancer. I don't know if I want to break. There's so many reasons. But when you do, I can't tell you how often, and I'm sure you experience, they grab my hands and say, I can't believe someone finally asked.
Yeah.
And they'll say to me, why would it take me 7 years to find someone like you? Or why was this never brought up? In situations you can't imagine. So it's just, it's not because they don't care or they don't want to talk about it. It's they don't feel comfortable bringing it up. You have to bring, even if you just say to them, it's very common to have these sexual issues after cancer treatment. We just want you to know we realize this and we have information and there's help available for you.
Yeah, absolutely. Thank you for reiterating.
Thank you very much.
Okay, thank you.
Well, it is now my privilege to close today's excellent proceedings and invite all of you back to tomorrow morning's session, which will begin at 9:30, where we talk about pregnancy. And this evening, we have programmed for you a beautiful reception that will be held just out by the posters. And this is also an opportunity for all of us to see the excellent posters. And there are really some extraordinary findings that are being presented within our poster session. So I urge all of you to get a glass of wine or a beer or sparkling water and come and see the posters. And I think you'll be surprised by the advances that are being made in the Oncofertility Consortium. Thank you very much, and see you tomorrow morning.